Ultrasound, EUS, in the evaluation of pancreatic cystic lesions and IPMN. Pancreatic cystic lesions, PCLs, and intraductal papillary mucinous neoplasms, IPMNs, are increasingly detected due to the widespread use of advanced imaging techniques. EUS has become a pivotal tool in evaluating these lesions due to its high resolution and ability to perform real-time imaging and tissue acquisition. Role of EUS in evaluation of pancreatic cystic lesions and IPMN. 1. Imaging characteristics. EUS provides detailed imaging of the cyst, helping to distinguish between benign and malignant lesions. Important characteristics assessed include cyst size, presence of septations, wall thickness, mural nodules, communication with pancreatic ducts. EUS is particularly valuable in evaluating IPMNs, helping to classify them as main duct, branch duct, or mixed type based on ductal involvement. 2. Cyst fluid analysis. EUS-guided fine needle aspiration, EUS-FNA, allows for the aspiration of cystic fluid, which is analyzed for cytology, identification of malignant cells, biochemical markers. Elevated carcinoembryonic antigen, CEA, 192 nanogram suggests mucinous cysts. Amylase levels. High levels suggest a pseudocyst. Molecular analysis. Detection of mutations in KRAS, GNAS TP53, and others to assess malignancy potential. 3. Risk stratification. EUS plays a key role in assessing the risk of malignancy in IPMN and other PCLs by identifying worrisome features and high-risk stigmata, such as cyst size 3 centimeters, enhancing mural nodules, main pancreatic duct dilation 10 millimeters. Patients with these features may require surgery or close surveillance based on the findings. Novel therapeutic applications of EUS. The role of EUS has evolved beyond diagnosis to include therapeutic interventions for pancreatic cystic lesions and IPMNs. Some of the novel therapeutic options are 1. EUS-guided cyst ablation. Agents used. Ethanol or paclitaxel is injected into the cyst cavity to induce sclerosis and ablation. Applications. Primarily used for benign or low-risk mucinous cysts to prevent malignant transformation. 2. EUS-guided drainage. Indicated for symptomatic pseudocysts or cystic lesions causing obstruction or infection. Utilizes lumen-opposing metal stents, LAMs, to connect the cyst to the gastrointestinal lumen for drainage. 3. EUS-guided drug delivery. Local delivery of chemotherapeutic agents for malignant cysts. Experimental use of nanoparticles and gene therapy via EUS for targeted treatment. 4. EUS-guided radiofrequency ablation, RFA, emerging modality for ablation of cystic lesions and small pancreatic neoplasms. Involves deploying an RFA probe into the cystic lesion to induce thermal injury and necrosis. 5. EUS-guided photodynamic therapy, PDT. Combines photosensitizing agents with light to destroy malignant cells in cystic lesions. Under investigation for its efficacy in IPMNs and cystic neoplasms. 6. EUS-guided cryoablation, a minimally invasive technique using cryoprobes to freeze and destroy abnormal cystic tissue, particularly useful for localized lesions without systemic involvement. Future directions. Advances in imaging, such as contrast-enhanced EUS and elastography, may further improve the accuracy of EUS in differentiating benign from malignant cysts. New molecular markers and targeted therapies are expected to enhance personalized management strategies. Artificial intelligence integration with EUS could optimize the evaluation and management of PCLs and IPMNs. By providing precise diagnostics and expanding therapeutic applications, EUS continues to revolutionize the management of pancreatic cystic lesions and IPMNs.